طيب بسم الله.
And it's my great pleasure again.
الحين you are live on YouTube. أنا الحين أدخل الناس. بسم الله. طيب الناس بدأوا يدخلون الحين. ما شاء الله المسجلين وصلوا 900. طيب بسم الله. ممكن تبدين دكتورة هبة؟
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, ladies and gentlemen. Thank you for joining us today. It's my great pleasure to introduce the first speaker of our webinar today, Professor Al-Kreya, the chairman of Translation and Genomic Department at King Faisal Specialist Hospital and Research Center. Prof. Fauzan is a well-known figure in genomic in our kingdom and worldwide. He's a 2020 recipient of the Kurt Stern Award, which is one of the authority in Mendelian genetics. He has published over 420 manuscripts that detail his lab discovery of hundreds of novel genes in human disease. So welcome, Prof. Fauzan, and stage is yours.
Thank you so much, Dr. Ahiba. Thanks to the organizers. Assalamu alaikum jami'an. It's a pleasure to be among colleagues and friends. And let me see if I can share my screen. I have a confession to make. I'm not a big fan of, let's see, this should be the one. Not a big fan of online lectures, but these are extraordinary times that call for extraordinary measures. So I apologize for not being with you physically, or for us not to be together physically, I guess. But let's hope to get something beneficial from this virtual experience. So what I would like to share with you is a fun ride I've had with colleagues of mine, many of whom are actually with us today, especially Dr. Mohammed Shagrani, who's the other panelists with me in this presentation. And what we learned about pediatric cholestasis from a genomics perspective and how this is really symptomatic of other heterogeneous disorders. Let's see if I can advance my slides. They're not advancing. Okay, so I don't need to explain this to this audience that the metabolism of bile is a complex process with so many players. And so it should come as no surprise that cholestasis is a very heterogeneous disorder, both clinically and genetically. And so this draws a nice parallel to the problem we have always had in clinical genomics, or clinical genetics rather, where when we're faced with a disorder that is highly heterogeneous, we do a lot of guesswork until recently in order to guess the most likely gene, so we can sequence that gene. And oftentimes our guess is wrong. So the patient has to be reassessed for the possibility of another gene, and so on and so forth. It's a very boring process that's lengthy, costly, inefficient, and patients hated, and doctors hated, and we really needed something to break us out of the cycle. And that thing is really genomics, you know, the ability to screen the entire or scan the entire genome, at least the coding part of it, which is the case with exome sequencing, in order to identify the causal variant without really having to even consider what the differential diagnosis is. They're really, really powerful stuff. And so instead of having to deal with this painful cycle that I showed you, we're breaking out of it completely by moving directly from the disorder to the diagnosis. And so what I like about this review that was published a couple of years ago in Nature Reviews in Gastroenterology and Hepatology is comparing the two approaches, the traditional and the genomics. And so they're showing the traditional algorithm of what to do. You do this, and if it's that, then it's probably this differential or that differential, and comparing it to the power of genomics, where you simply do that one test and bam, you get your diagnosis without having to go through that very convoluted process. And so I would like to share with you my journey with cholestasis and the power of genomics of cholestasis. And I like to share with you the first story really I had to deal with after establishing my lab at King Faisal. And so the story starts with this family that you're probably going to be asking yourselves, why is he sharing with us this eye story when this is a talk about cholestasis? But you will know why in a moment. So this is a novel syndrome in which the retinal artery undergoes aneurysmic changes. So it was named familial retinal artery macroaneurysm. It was described by Dr. Imad Aboud and colleague many years before we even started. And so when I started, they figured, okay, maybe this is a good way to collaborate to figure out what the cause of this condition is. And so to make long story short, we had a lot of families with this disorder. And what we found to be very interesting is, even though they lack dysmorphic features, they do have syndromic associations, specifically in the heart. So they have supravalvular pulmonary stenosis, and you will see what this is relevant in a moment. And so we mapped it, we identified the causal gene, IGFBP7, which turned out to be extremely important for eye development. And I'm not going to go through this, but I will tell you that we later identified a very interesting association. About a quarter of these patients have cholestasis. And what's really funny is that these patients, because they have cholestasis and they have heart disease in the form of pulmonary stenosis, several of them were actually misdiagnosed as Alagille syndrome. But they always turned out negative, obviously, for the Alagille genes. And so this turned out to be a real association. In addition to other features, if you're interested, I'll be more than happy to talk about them in more detail, specifically cerebral artery aneurysm and other aneurysmal changes. So that was my first foray into cholestasis. But then, as my very close friend, Dr. Mohammed Chagrani, he told me about the struggle they have with, getting to the bottom of cholestasis, genetically speaking. And so we agreed to use a multi-gene panel, taking advantage of next generation sequencing power. And in this elegant study that was put together by Dr. Mohammed Chagrani, we had around 100 patients with various forms of cholestasis after, of course, the exclusion of biliary atresia. And, as you would expect for a heterogeneous disorder, we had hits in multiple genes with a high diagnostic rate of almost 2/3 of patients. And we'll talk about what happens to the remaining third of patients in a moment. But what I think is a nice take-home message here is that in about 40%, the diagnosis was actually wrong. You have patients with ABCB4 cholestasis who were misdiagnosed as Wilson's disease. You have a patient with tyrosinemia who was diagnosed with eosinophilic cholestasis. It's really an eye-opener when it comes to how we should humble ourselves as clinicians, knowing our limitations and thinking of how we can free our patients from being at the mercy of whether or not the clinician happens to guess the right diagnosis. And that's the power of genomics. There were missed opportunities, as you would imagine, of patients who could have benefited from specific therapies, and yet that wasn't available to them because the specific diagnosis wasn't made. And needless to say, the opportunity for prevention was not there when patients did not have a molecular diagnosis, which we're hoping to change through this approach. And another take-home message from this exercise is that there is 1 in 87 Saudis are a carrier, at least, and this is, by the way, a minimum estimate of one of these pathogenic variants, which translates to a remarkably high disease burden in the society. We're talking, and again, this is at a minimum, we're talking just founder variants. We're not even considering private variants. 1 in 7,000 compared to, if you look at the literature, people talk about 1 in 15,000, 1 in 20,000. Here we're talking 1 in 7,000. And again, this is a bare minimum. Okay, so what I like about the part that I mentioned where a good 40% receive the wrong diagnosis, you shouldn't feel bad as gastroenterologists. When we did this exercise on thousands of families with all kinds of Mendelian diseases, what we found very interesting is that in about 4/5 and about 80% of cases, the diagnosis in the chart was actually wrong before it was corrected by exome sequencing. So this is not to show that doctors are bad. It's just, telling us real life data that we cannot rely simply on our clinical judgment. And we really need the complementarity of a genomics approach to fill in this gap created by our imperfect clinical judgment. Okay, so how about the negative cases? I promise to go back to these negative cases. And that's where fun really starts, at least from my perspective as a human genetics researcher who's really interested in exploring the unknown and making novel discoveries. So what you need to know, and I apologize, I don't know if all the audience is from Saudi Arabia or if we have international audience as well, but be it as it may, I just want to remind people of something very unique when you're dealing with a consanguineous family. So in this consanguineous loop, I just want you to follow this light blue chromosome. As you know, for each chromosome, we have 2 homologs, right? So I just want you to follow this homolog as it gets passed on through the generations. So it's passed on to the 2 sons, who then pass it on to the son and daughter, who are now first cousins. And so their son has a 25% chance of receiving the exact same copy of that chromosome from both parents, making that individual autozygous. Now, obviously, you don't just inherit chromosomes unchanged. There's the process of crossing over, which I'm representing here with all these bars. And this means that if the ancestral or the founder haplotype, that chromosomal segment, harbors a recessive variant, this autosomal recessive variant will be unnoticed in this generation, and in this generation, and in this generation. But bam, this individual now has 2 copies of this recessive variant and will develop the disease. Now, the reason I'm showing you all this complexity of crossing over is just for one simple take-home message, which is that, yes, in a consanguineous family, you're more likely to develop a recessive disease, but the upside is knowing where to look for the variant is a huge advantage. And so we look for these islands of autozygosity, and that's a process called positional mapping. That's how we know where the gene is. Just like the example I showed you earlier about IGFBP7 in familial retinal artery macroaneurysm. And so if you combine this with the fact that we tend to have large families and oftentimes extended families, that makes the process of positional mapping even more efficient. And so I'll share with you a fun exercise we had with a number of colleagues, primarily with Dr. Sami Wali, who referred several cases to us that had negative exome sequencing. So even though exome sequencing was performed on these patients with cholestasis, there was no positive result. And so to make long story short, we used the power of positional mapping I told you about, and we identified in these 3 families KIF12, multiple KIF12 variants, which then turned out to be an important gene for cholestasis. And then there was this family that had a very unique tongue presentation. And again, in addition to cholestasis, and again, we identified a novel gene, PPM1F. And in these 2 families, one of them actually came from Dr. Mohammed and Haidib too, this one. And again, we used the exact same strategy of positional mapping with exome sequencing to zero in on the causal gene, USP53 here and LSR. And finally, this family that's really, really unique because of their syndromic presentation. And so a very severe presentation of cholestasis in addition to highly dysmorphic faces. And again, we were able to map them, as you see in this circular representation of the genome, to a single locus where we identified WDR83OS. And all of these, 5 novel genes in a single paper that we published in Genetics and Medicine. And what's really reassuring, so that's the paper I referred to. Just after we published that paper, a lot of other groups started showing additional variants in the genes we identified. And so now KIF12 has been confirmed by others, as you see in this paper. This is USP53, again, confirmed by another group. And there's the LSR confirmed by another group. And the WDR-OS3 that I showed you earlier is also being confirmed by another group, although the paper hasn't been published yet. Another novel gene discovery story that I'd like to share with you is this form of cholestasis that is related to ciliopathy. So those of you who know me know that I'm really interested in cilia disorders. Those of you who are not familiar with primary cilia disorders, these are clinical manifestations that can be traced back to abnormal primary cilium. So think of, for example, Bardet-Biedl syndrome, Joubert syndrome, gene asphyxiating thoracic dystrophy, and so forth. And so it was really remarkable when we had all these families referred by multiple colleagues, including Dr. Sami Wali. And they had ciliopathy presentation in terms of the extradigit, the polydactyly, the hydrocephalus, but they also had very, very severe cholestasis. In fact, several of these patients died, and those who did not die only survived because of liver transplant. It was a really severe presentation. And we found that indeed their liver biopsy is highly suggestive of a ciliary process, because as you know, cholangiocytes do have these primary cilia. And so when the cilium is abnormal, then you get very abnormal polarity of the cholangiocyte. And so you get this abnormal ductal plate development and formation in the liver. And so we were able to map this syndrome to a single locus, as shown here in this peak. And we solved it at the level of one single gene, TTC26, which we showed to be very important for early liver development, as you would imagine, for a developmental gene that's related to the ciliary function. And I don't know if you can see this here, it's a little blocked from my side because of the Zoom panel, but I hope you can see that the cilium compared to the difference between the control and the patient in terms of the transport along the ciliary shaft is abnormal in these patients. And this is just to show that the signaling, the sonic Hitchcock signaling is abnormal. And I'm not going to get too technical, but I would say that even the variation in length is abnormal in the cilium of these patients. And again, it's always nice to see independent confirmation. Dr. Shagrani was just telling me the other day that he actually identified additional patients with this disorder. And this is a paper that came out from Israel, where they found the exact same founder variant. It's actually an ancient, one of the variants that we identified was an ancient Arab variant that's also present in Palestinians. So they identified it in several patients as well. Okay, now something else that's very interesting and that's of great relevance to you as you consider, why is my patient negative? I did the right thing. I heard this talk about the importance of genomics. I did exome sequencing. My patient's negative. Now, this is a family that clearly has cholestasis in an autosomal recessive manner. Exome sequencing is negative. We were able to map it to a single locus, and lo and behold, now we understand why exome sequencing is negative. It's because the causal variant is extremely deep. This is +335. That's 335 away from the region that we typically capture and sequence. And so here's another example of how positional mapping can really help you drill down to the level of the causal variant, even when it's far away from the coding sequence. And so we were able to identify that variant that way. And similarly, this is a family referred by Dr. Abdurrahman Husseini, from King Fahd Medical City who tested negative on exome sequencing. And again, after we mapped it to a known gene, SCIV2L, which causes that syndrome, as you know. And it turns out that it was just a technical error in exome because of the tricky nature of the variant. It was missed, and then we identified it. Okay, very quickly, after we saw the benefit of doing this, we decided maybe we should do this almost like the point of care kind of exome sequencing. We call it flash exome sequencer. So in less than 48 hours, we reserve this to really sick patients. And, we've had great luck with these cases with a hit rate of nearly 50%. And I'll just share with you 2 cases to show how this can be extremely helpful in making a clinical decision that is of great relevance to the future of the patient. So here I'm sharing with you 2 almost identical stories. One of a 2-month-old infant with cholestatic jaundice present with decompensated liver failure. So the folks at liver transplant needed an answer as soon as possible to know if this patient is a good candidate. And we identified a clearly truncating variant in BAT, which confirms that this would be a very good candidate for liver transplant. On the other hand, another identical 2-month-old presented the same way, but we identified a DGUK variant, which tells us that this is a very severe mitochondrial systemic disease, and so the patient is not a good candidate for liver transplant. And so I hope I was able to convince you that a genomics first approach exposes an unacceptable level of imprecision in contemporary hepatology, which should encourage us to adopt this new era of a genomics first approach. Is not to tell ourselves that we're bad clinicians, just that this is the reality of life, that we have limitations using our clinical tools. And so genomics is there to help us. And a genomics first approach promises to really revolutionize the way clinicians expend their energy. So instead of wasting your time trying to figure out what's going on in terms of the diagnosis, that diagnostic part can be, for the most part, taken care of by a genomics approach. And so your energy can be expended into thinking, what can I do to help the patient, as opposed to trying to figure out what the patient has in the first place. And I hope I was also able to convince you of the tremendous opportunities we have in terms of making novel discoveries in the field of genetic cholestasis in Saudi Arabia because of the unique population. And so I'll be very, very happy to collaborate with any of you who has a patient with cholestasis who tests negative on exome sequencing or genome sequencing. My email address should be part of the invitation that you received, and I'll be more than happy to receive your email about any patient that you'd like us to collaborate with who meets these criteria. At the end, I'd like to thank all the members of the lab who made this work possible. I'm simply presenting on their behalf, all the collaborating scientists and collaborating physicians. I hope I was able to mention the names of most of those who contributed those cases, the genotyping sequencing core facilities, funding agencies, and thank you for your attention. Happy to take questions.
Thank you so much, Prof. Fawzan, for this excellent presentation. We will wait for any questions to Prof. Fawzan, and then we'll proceed with the other 2 topics.
Anyone have a question, he can raise his hand, and they will let the mic is for him accessing.
Or they could type the questions through the Q&A, right?
Of course, yes.
Yeah, please don't use the chat button for your questions because they're very hard to keep. Yeah, Q&A, please.
Yeah. So While waiting for the questions, let me ask you a question, Prof. Fawzan. It's a common question we heard from our colleague usually whenever we have a sick patient, especially that we receive our patients from referral hospital, that how is the blood transfusion affect the result of whole exome sequences? And you know, sometimes, and we did that, we send saliva sample and we have results. Can you comment on this, please?
Yeah, this is a common question we receive. And I think people underestimate the fact that blood transfusion these days is almost never a whole blood transfusion. It's usually packed red blood cells. And these are very, very depleted for white blood cells. And you should know that DNA is, extracted for the most part from white blood cells. And so, in a span of days, really, any tiny remnant of DNA from white blood cells in those packed RBC transfusion will not be there and will not affect the the accuracy of the test. And again, I'm talking about packed red blood cells as opposed to whole blood transfusion. Whole blood transfusion may be another story, but I think most people are dealing with packed red blood cell transfusion as opposed to whole blood.
Thank you. There's one question, says, how can we make the genetic approach test first regarding the timely manner of test result? I think he is.
So yeah, I guess I mentioned two scenarios. One is the regular exome sequencing, and the other is flash exome sequencing. Now, flash exome sequencing is done on a research basis in our institution, but there are diagnostic labs that do offer it, and they would give you a turnaround time in a matter of a couple of weeks. Or if you believe your patient is very sick and you need a very urgent answer, our protocol is still active, and we'll be more than happy to recruit your patient and give you the answer within 72 hours. It's something we are more than happy to do. Our protocol is not limited to King Faisal. We're very happy to receive referrals from anywhere really within the country. So I hope that answers the question. I see another question by Razan Bedr. Would you like me to read it, or would you like to read it? How does it work? Happy to read it. Okay, it says, yeah. Thanks, wonderful presentation. How can we collaborate with your lab to send all our genetics to Saudi labs rather than CTC or other international labs? Okay, yeah, this is a great question. It's actually embarrassing that with all these years of dealing with Mendelian diseases in the country, we don't have a major reference lab in the country. The good news is this is changing very soon. We actually just started at a small scale at King Faisal, and hopefully as we get the CAP accreditation process taken care of, this will be hopefully the dream that we're all looking forward to, which is having a reference lab in the country for your cases. In terms of collaboration on a research basis, by all means, obviously my lab is not a diagnostic lab, it's a research lab. So I would be hesitant to just accept all cases of cholestasis because many of them are going to turn out to be, known genes. And that would not be a very good, use of our limited resources. However, as I said, if you do get access to exome sequencing through whatever diagnostic lab, whether domestically or internationally, and the result is negative, or if the result is ambiguous because the variant has not been seen before and you'd like to run it by our database, again, please don't hesitate. We'll be more than happy to collaborate. And then I see another question. Sorry, go ahead, Dr. Hiba.
No. Most of the comment that, how we access your labs and to send from, from the Gulf region and other region in Saudi Arabia. One question here says, if a clinical diagnosis is highly suspected, but was is negative, what is your advice?
What is the question? Sorry, can you repeat it again?
If the clinical diagnosis is highly suspected, but WAS is negative, what is your advice?
Yeah, so if you're certain of a certain genetic form of cholestasis, and the exome sequencing is negative, we have several possibilities, right? One is the causal variant, the underlying mutation, is not picked up by exome because of its nature. Maybe it's very deep within the intron. And so there are ways to handle this on a research basis, which is to do like, the example I mentioned of those two families that tested negative. And, we didn't discover any novel gene. We discovered variants within known genes. They're just very deep. Again, this is something we're more than happy to collaborate with on a research basis. Now, if you're thinking, okay, what would be the alternative from a clinical perspective? Obviously, in the future, exome sequencing will be replaced by whole genome sequencing. And hopefully whole genome sequencing would cover that for you. Now, the other possibility is that even though you know that there's only one gene for that condition, you'll be surprised. You may be the one discovering a novel gene for that condition. And that's why your exome sequencing is negative. And again, this is a scenario that we're more than happy to collaborate with you on to get to the bottom of why exome is negative. Is it because it's a novel gene that we're going to discover together, or is it because of a tricky variant class that we should be able to identify using positional mapping?
Okay. I'm just choosing the. Okay, another question says, do you think, Prof. Fauzan, that we will see the era of neonatal screening using WESH soon?
So in theory, I have no doubt that babies are going to have their genome sequenced before they're even born as part of the genomic revolution. So as part of caring for women prenatally, the entire genome of the baby will be sequenced and will be deposited in the future medical record of that baby. So that's the future, though. And there are multiple challenges towards achieving that. But I think I will just leave you with one ethical question that we need to address, which is, if you were to do whole genome sequencing or whole exome sequencing in a neonate, there is a problem. Yes, you will be diagnosing all these metabolic conditions before they even manifest. You'll be able to predict a lot of things. But remember, when you deal with millions of variants in an individual, it's inevitable that you will be dealing with variants of uncertain significance. And I just want you to think of the nightmare scenario we will be creating by sharing variants of uncertain significance with parents who freak out potentially for no reason. And we know how painful this is from our experience with newborn screening for metabolic conditions. When you run the metabolic profile, yes, for the most part, you can tell that these are normal babies and these are abnormal babies, but there is that gray zone that creates so much anxiety in the minds of parents. And this will be just compounded if we were to do this at the genome level, just as a pure number game, because we're dealing with millions and millions of variants. So yeah, that will be the future. But as you can imagine, there are, apart from the technical hurdles, there are ethical hurdles that we need to think about very carefully before we roll it out, even if we're capable of doing it technically.
I think this is the last question we can have. That do you think that with the genetic era, the genetic or the exome sequences will replace or decrease the need for liver biopsies in the future?
I do think that invasive procedures will decline. We're already seeing this, for example, in the area of autopsy. Now that we know how to diagnose the cause of death using molecular autopsy. And so I don't see any reason why the trend will be any different with other invasive procedures like, liver biopsies. We know, for example, after our neuromuscular colleagues, in urology adopted exome sequencing, their use of muscle biopsy dropped drastically. In fact, if you look at the guidelines for the diagnosis of Duchenne muscular dystrophy these days, you will see from, very highly reputable organizations, they're dropping the need for muscle biopsy altogether, because the vast majority of these patients can be diagnosed with confidence just simply using genomics. So the short answer is yes, I do think these will be declining.
All right. I think no more questions.
Dr. Heba?
Yes, Dr.
I
Shagran.
wanted to comment before Fauzan will leave us. Good evening, all. Actually, in King Faisal, we are very, very grateful and thankful for all the effort done by Dr. Fauzan. Yani, he changed really the pediatric hepatology service pre and post-liver transplantation. He even, his work guide us for the management post-liver transplantation, and I will show this in my pictures. So Anna, I think we were very lucky and to have Dr. Fauzan in King Faisal. And I think he's changing the map of many actually diseases, not only in pediatric liver, but what he did in cholestatic liver disease is unbelievable. And it has been done by one person who is interested in his work, who wanted to help. So I should really always to be thankful for him. We are all proud to have Dr. Fauzan Al-Khair in this field. And I'm also proud that Fauzan Al-Khair was my classmate during the medical college. So thank you very much, Fauzan. I get the opportunity before you will leave. By the way, guys, Fauzan is too late because he's sleeping so early.
Okay, now all my dark secrets are being revealed in public. Dr. Hamad Shagrani, I don't mean this as to reciprocate, but I want you to know that I'm absolutely grateful, first of all, for the very kind words, but also for teaching me so much about cholestasis. This was really a new uncharted water for me, and you've been a great mentor in telling me all about cholestasis and getting me all excited. And I'm really glad to hear that I've been of some help to you and your colleagues. And again, we would not have done this alone. This was teamwork, and I'm very grateful for the endless support and your friendly collaboration over the years. And I look forward to continuing this in the future with other colleagues who are in the audience as well. So thank you so much.
All right, so thank you so much, Professor, for this great and amazing presentation and discussion. And I cannot add more to Dr. Shagrani. You really set the bar high for us at King Faisal and all over the kingdom. Thank you so much. Moving to the next talk, I will just talk briefly. I have a case presentation, and then we'll have a topic by Dr. Muhammad Shagrani. So next, please. So I will present two cases. I have nothing to disclose. The first case is a 2-month-old Saudi boy transferred from high northern region to our hospital as a case of normal gamma GT cholestasis for investigation. He was born at full term by vaginal delivery and eventual pregnancy. He needed an ICU admission for 3 days as due to autoimmune thrombocytopenia that treated with IVIG and platelet transfusion, and then discharged home in a good condition. Next, please. At age of 4 days, he was admitted to the hospital with chief complaint of jaundice, stayed 4 days, and then labeled to have direct hyperbilirubinemia. He was started on vitamin K and ursodeoxycholic acid. In regard to his family history, consanguineous parents, both are healthy. He has one older brother, two brothers are healthy also, and no family history of liver, hematological, metabolic, or genetic disease. Physical examination were unremarkable apart from the jaundice and hepatosplenomegaly. Next. His investigations, when we received this patient, have showed elevated transaminases, ALT of 475 with AST of thousands, normal gamma GT 110 for his age at that time when he was at 2 months, high alkaline phosphatase and direct bilirubin of 300 with high bile acid, serum bile acid. Next. His INR initially was 1.5 and then was reached to 6 in 10 days with very low vitamin E and D levels. Next. So this patient apparently, he fit the criteria of neonatal acute liver failure. So we did all the extensive workup for other metabolic causes, include serum pyruvate kinase, lactic acid, gout, urine producing substance, all were negative. And we noticed that he has high alpha-fetoprotein. Next. Skeletal survey showed diffuse osteopenia. Ultrasound abdomen showed increased liver parenchymal echogenicity, no focal lesion or intrahepatic tree dilatation, and echocardiogram was normal. Due to progressive coagulopathy and decompensated liver disease, we sent, and this is, by the way, one of the cases that Prof. Fauzan mentioned, we sent for him a flash West, and we got the result in almost 48 hours and came positive for a pathogenic variant with the PAT, which is one gene for a mutation for familial hypercholesterolemia. For this, this is, pictures of how they are doing and reading the whole exome sequences. This patient, next please. This patient underwent living-related donor liver transplantation at the age of 3 months. And I will show you the explanted liver biopsy in the coming slide. As we can see, he had giant cell transformation and severe cholestasis with pericellular fibrosis, and the cytokeratin 19 showed degree of the ductal proliferation, as we can see here. Next, please. Next. Okay, moving to the second case, we received a 4-month-old female transferred from Ashir, South region, again as a case of normal gamma GT cholestasis. She was born full-term by CS due to breech presentation with an eventual pregnancy. She was discharged with mother in a good condition. At the age of 1 week, she started to have jaundice, no associated symptoms, and she was reassured with an impression of physiological jaundice. Afterward, her jaundice persists for the first month with occasional itching, irritability. So the family sought medical advice again, and she was found to have normal gamma GT cholestasis and started on ursodeoxycholic acid. 3 months later, she had progressive jaundice, itching, increased bilirubin level, and at that time she was transferred to King Faisal Specialist Hospital, Jeddah branch, and have been followed there by the hepatologist. It's worth to mention that she had femur fractures, needed cast. Family history, again, positive consanguinity, other sister, she's normal, and no family history of liver or metabolic disease. In regard her examination, again, jaundice, and she had hepatosplenomegaly. She was severely failure to thrive with weight and height below the 3rd percentile. Her investigation showed normal gamma GT cholestasis with mild elevation of transaminases, again high bile acid. She had INR between 1.5 to 1.6 with very low levels of vitamin E and D, and we noticed that she had hypocalcemia, hypophosphatemia, and hypomagnesemia as well. Next. During her follow-up, she was referred to us after being following up in Jeddah for almost 1.5 years. They did the whole exome sequences, which showed the pathogenic variant of tight junction protein 2, which another cause of familial cholestasis. Next, this patient, her skeletal survey showed diffuse osteopenia and heel fractures with bowing. Ultrasound was showing mild hepatomegaly and echo was normal. So again, she underwent, due to her, severe failure to thrive, a sign of portal hypertension, she underwent living-related donor liver transplantation at age of 2 years and 6 months. And again, this is her explanted liver biopsy that showed, we can see the micronodular cirrhosis. The cirrhosis nodules is very obvious here with cholestasis and giant cell malformation. Next. So, familial hyperkalemia characterized by elevated serum bile acid, itching, and fat malabsorption. Fat malabsorption reflecting low intestinal bile acid level was manifested by failure to thrive, potential life-threatening vitamin K-dependent coagulopathy, and rickets. Usually, those patients respond to treatment with ursodeoxycholic acid. This is when we discovered the disease earlier, let's say in 2003, was explained or was, explained in the literature as a benign disease. So familial hyperkalemia was identified in 2003 in Amish individuals and associated with mutation in 2 genes, tight junction protein 2 and the bile acid coenzyme encoded by BAT gene. This is again the BAT gene, as we know, in the last step of cholesterol metabolism. The conjugated, the bile acid will be conjugated with the amino acid leucine tyrine, and that's when allow the normal bile acid diffusion through the canalicular membrane. Whenever you have mutation in this gene, you would have a very toxic conjugated bile acid that flows and explains the hepatocellular injury and the cholangiopathy. Tight junction protein, or we can call it zona occludin 2. It's a cytoplasmic component of cell-to-cell junction complex expressed in most, if not all, epithelia. That's why now the new literatures and papers talking about lung manifestations, hearing impairment as well. This protein zipping is zipping the apical membrane of the adjacent hepatocyte, and it prevents the back diffusion of the bile acid from the lumen of the bile canaliculi to the blood circulation. So this paper was published in 2014 by Melissa and Dr. Richard Thompson from King's College. They reported all the patients with the tight junction protein, they have severe liver disease. 9 of 12 have required liver transplantation to have stable liver disease and mild portal hypertension, and 1 died at the age of 13 months. In addition, 1 had recurrent unexplained hematoma despite normal clotting at 8 years, and 1 has poorly characterized lung disease. Dr. Shagrani and his group, they shared one of their abstracts in the SASPGHAN meeting 2019. They share their data about familial hyperkalemia presented with severe progressive intrahepatic cholestasis secondary to homozygous mutation in both tight junction protein and BAT. And currently, almost we have maybe 14 to 20 patients with tight junction protein and 4 patients with BAT mutation. So my take-home message is normal gamma GT cholestasis with aggressive cholestatic liver disease at early age. Always think about familial hyperkalemia rather than the perfect type 2. They would present and need liver transplant a bit later in age. Again, to emphasize the importance of genetic tests in such cases and early transfer to higher center for further evaluation and liver transplantation, and also for genetic counseling, especially with in our country with high consanguineous marriage. Thank you. We'll move to before receiving any questions, we'll move to the next, to the third speaker, Dr. Mohammed Shagrani, and then we'll have the questions at the end. It's my great pleasure to introduce Dr. Shagrani. He's my great mentor in pediatric hepatology. He's a consultant in pediatric transplant hepatology at King Faisal Specialist Hospital, associate professor at Faisal University. He's one of the members of represent the pediatric hepatology committee in SASPGHAN group, and also he's a primary investigator in the clinical trial of perfect with a new treatment and new therapy in perfect. Welcome, Dr. Shagrani, and the mic is yours.
Can you unmute yourself, Dr.
السلام
Muhammad?
عليكم.
Salam.
مساء الخير جميعا. Good evening for all. I would like really to thank Dr. Ali Mhedib and Dr. Hiba and the whole organizing committee and Dr. Dafir for the invitation. And I'm very happy to be with you tonight. It's my great pleasure really also to share this panel with Hiba and Professor Fawzan. So we heard about the genetics. We have some cases presenting, like 2 cases presented by Dr. Hiba. So I will take you to the clinical, or let us say pathophysiological part of cholestasis. I will try to have it concise with just highlights for what we learned really over the years and how this has changed our management pre and post liver transplantation. So disclosure, currently I'm the PI for a double-blind randomized placebo-controlled phase 3 study to demonstrate efficacy and safety of AFI investigator drugs labeled as A4250 in children with progressive familial intrahepatic cholestasis phase 3 clinical trial in Saudi Arabia in King Faisal Hospital. So this is just a quick slide to show you our indication of liver transplantation. This is up to 2019. And you can see that among all the indication, I mean, progressive familial intrahepatic cholestasis is #1. And when we say BIFIC, it doesn't mean like BIFIC 1 and 2 and 3. I'm talking here about all type of progressive familial intrahepatic cholestasis. So if you look for the relation between genetics and liver disease, you will see that this is going back to 1992. And at that time, it was the early discovery of the loci of proteins for Gilbert and Kirkener-Jarre syndrome. After that, in 1993, came the ATP7B in Wilson disease. And at that time, the known of the expression of the protein was more powerful than the genetic mutation. But actually, in the recent year, it is the opposite. Now, knowing the genetics is more than the protein and the protein coming after. And this is showing you how the revolution of genetics changed in the last 10 to 15 years. 1998 was distinguished years where BIFIC 1 and 2 and 3 came in the same year. And you can see in 2014, there was the labeling of TGB2 to BIFIC type 4, which is, I know as a fact that even the one who published this in Journal of Hepatology, he regret to name this as BIFIC 4, and he will prefer to keep it as TGB type 2. So seeing all this, I mean, paper about genetics and mutation and cholestatic liver disease, it was a little bit painful that most of those papers, which came from Europe or from North America, all the blood sample has been coming actually from the Gulf areas and mainly from Saudi Arabia. So, and even in some of them, even the authors were just from North America and Europe, and what we have is just a diagnosis. So at that time, something really need to be done different. So this is the paper. Dr. Fawzan highlights some of the result. This was about the genetic profiling of children with advanced cholestatic liver disease, and it was experience of a large pediatric liver transplant center. This is what we did in King Faisal Hospital. The work was started in end of 2013, and we finished all of this by 2014, 2015. And really what has been shown that the likely causal mutation was identified in the majority. Actually, we make a sample of 98, as Fawzan mentioned, we exclude the biliary atresia. Those with known metabolic liver disease, we put them as either positive or negative control, just to see if our genetic mutation and our GI panel is of high validity. And we found that we managed to diagnose almost 61 to 64 of the patient, and the most common mutated genes were, as expected, ABCB11 came number 1, followed by the ABCB4. And we were surprised that we have a lot of cases of TGP2, which is represent almost 12%. This is almost, Dr. Fawzan showed you the same slide. So you can see PCEP, the majority, and MDR3 coming second. And I can tell you since 2015 until today, almost we are running the same percentage. So ABCB11 is number 1 and MDR3 is number 2. Those who know me, they know that I love those slides. So I think most of the cholestatic and most of the science is here. And whenever you know what's going on in the anterior hepatic circulation, then everything is easy. So if you will go to this slide, so this is showing you how you have the bile acid synthesis. So we have the cholesterol as the substrate. Then we go through all the pathways of the bile acid synthesis, ended with the primary bile acid, which is cholic and chenodeoxycholic acid. Those cholic and chenodeoxycholic acid, we call them primary bile acid, and usually they are unconjugated. And whenever they are unconjugated, they are so blind in the cytoplasm, and they will go anywhere apart from stasis in the hepatocyte and damage it. So this is the reason we have the process of conjugation with taurine and glycine, which is the 2 amino acid will change the bile acid to bile salt. So changing the primary bile acid to conjugated primary bile acid or bile salt, this is the key point, which is will make the bile salt recognized by bile salt export pump. This is the reason that the name is bile salt. It is not bile acid export pump. So without conjugation, the bile salt export pump will never recognize the bile salt. This is number 1. Without conjugation, this bile acid will stay here and it will never reach to the bile salt. So the conjugation helping intraverse or shuttling the primary bile acid to the canalicular membrane, and in the recognition of bile salt export pump to this conjugated bile acid. We know after the conjugation, the bile salt export pump from the name will pump the bile salt inside the canaliculus, and from here the story of micelle formation will start. The micelle formation will contain bile salt, will contain bilirubin, and the cholesterol, which came from the pathway, and other metabolites. And the one of the most important is the phosphatidylcholine. What is the job of this? This is to make the bile salt non-toxic, because until this stage, the bile salt is detergent material and it is very toxic. And we have here the FIC1 protein, which is until now it is controversial. Personally, I would prefer to call it flipase protein. The meaning of this that it will play between the phosphatidylcholine and serine to keep them around the canalicular membrane, which is make this membrane stable so the PSEP will be functioning very well. So this is the reason that the name is flipase protein, and this is the reason that BIFIC1 and BIFIC2, they look like each other, except that when you do histopathology for a BIFIC1, the liver almost look normal, while when you do it in PSEP, the liver is showing you a lot of damage, giant cell hepatitis, and degeneration. And why is that? This is my explanation, and we published this, that we think in the case of PSEP, the bile salt will reach here, but it will never be recognized by bile salt export pump. And this is the reason it will go back and it will damage the hepatocyte. In cases of FIC1 protein abnormality, either total absent or deficiency, the PSEP is there, so the bile salt will reach to the bile salt export pump, but this will not functioning well, so it will never be pumped inside the canaliculus. So this is the reason that there is no toxic bile salt inside the hepatocyte. And this is the reason when you do BIFIC1 biopsy, you feel it almost normal with just some blunt cholestasis. MDR3, as we mentioned, this protein will be responsible for pushing the phospholipid inside. Phospholipid, when it will go inside the micelle, it will go to the toxic part of the bile salt conjugated there, and they will change the bile salt to be non-toxic. TGB2, this has been mentioned by Dr. HIPAA, and it is at the paracellular level, keep the zipping around the both hepatocyte, and will prevent the back diffusion, because if you will go with osmosis, the concentration of the bile salt in the canaliculus is 100 times more than the blood circulation. So normally it should be back diffused. The presence of tight junction is the reason that this back diffusion will never happen. Just to complete the picture, we have here two proteins. Until now, there is no any expression of those proteins for any genetic disease so far. One of them is the sodium taurocholate peptide, and the one organic anion peptides. And those two, they are responsible for the reabsorption of the bile salt coming from the enterohepatic circulation after the reabsorption at the terminal. So if you will go back, this is the same slide. So here is the synthesis, the conjugation, going through the biliary system, going through the small intestine, and here is the main player in the reabsorption of 95 of the serum bile acid by the apical sodium bile salt transporter. And this is the reason most of the research now is going around aspect and around fixer, which is, I will show it to you in another slide. Those 95% will go through the portal blood and then reuptake again by the hepatocyte, as I mentioned, by NTCP and OTPs. And this is the enterohepatic circulation. So simply, any mutation, either structural, functional, congenital anomalies, will cause abnormality in this, the enterohepatic circulation, will cause cholestasis. So you cannot define cholestasis as a high bilirubin or high serum bile acid or high gamma GT. No, you need to define the cholestasis as impairment of bile acid flow with or without retention of the bile acid in the hepatocyte. By putting this definition, you can include all the cholestatic diseases we know. But if you keep looking to gamma GT alone, or to the serum bile acid, or to the bilirubin, then you will miss a lot. As an example, if you will tell me that bilirubin is mandatory to be high whenever you have cholestasis, this is not true in some cases of familial hyperkalemia. If you will tell me that serum bile acid need to be high, this is not true in bile acid synthesis defect. So looking for this is not enough, and I think this is the best definition for cholestasis, and we published this in 2014. So going through the diseases, I will try to be very quick, and I will give you highlight from our clinical cases. So BIFIC1, as we know all, it is a mutation in the ATP8B1 gene, and it occurs at different loci. The amino acid substitution in BIFIC1 are usually in the essential part, while in PREC is located in non-essential part of the protein. And this is the normal. When we have this is what's happening when you have PREC, which is benign recurrent intrahepatic cholestasis, because the protein is there, but it is down-regulated. BIFIC1, the protein, either it is totally absent or it is very deficient. So just quickly, we know that BIFIC1 is systemic disease comparing with BIFIC2, and there is systemic manifestation of the disease because the FIC1 protein is expression in many tissues. So this is one of the paper we published in Journal of Hepatology about the impact of genotype, serum bile acid, and surgical biliary diversion on native liver survival in FIC1 deficiency. We published this paper in 2021, and actually in this paper, we confirm that the genotype will really play a major role in the management of BIFIC1, because until now, all the data about liver transplantation in BIFIC1, it is not promising. It is systemic disease. Those patients will have allograft steatosis, post-transplantation, failure to thrive, and some of them, they will have high risk of mortality because of metabolic syndrome. So in BIFIC1, liver transplantation is not curable. PSEB disease or BIFIC2, I would like to call them PSEB. Under PSEB diseases, we have BIFIC2 and we have PREC2. And again, whenever the mutation severe, it will cause for you the BIFIC2. Whenever the mutation is mild, will cause for you benign recurrent intrahepatic cholestasis. And this is one of the things why you need to work with a good geneticist, and you need to know more about the mutation, type of mutation, because this will affect the management of those patients. Not all of those patients, they need liver transplantation. So we published this paper actually about impact of genotype serum bile acid, as I mentioned on the FIC1, and we published in the same, in Hepatology Journal in 2021 August paper about looking for PIFIC2. And this is what we made over 2 years, the NAP-ED. This is, it is the largest global database of genotype patients with PSEP deficiency. And anyone really interested to be part of this, you can contact me offline. We are collecting all the data about PIFIC2 patients, internationally, multi-centers. And this is one of the largest data available. And what we showed in our publication, that the genotype of patient with severe bile salt export pump deficiency is associated with clinical outcome and the success of therapeutic intervention. And this is really changing. The management will tell you when you wanted to wait, when you wanted to treat patients, when you wanted to give more time for the medication, when you want to really to do biliary diversion, and when you wanted to send the patient for liver transplantation. So this will be a big help and guide for you to personalize clinical care throughout childhood and adulthood in patients with this disease. PIFIC3, it's really amazing disease because mutation at PCB4 causing MDR3 deficiency will give you different phenotype. So different mutation can cause for you different kind of MDR3 dysfunction. Nonsense mutation will give you the PIFIC3, which is we saw in pediatric. Missense mutation will give you less severe phenotype. And the heterozygous mutation, EBCB4, can cause variety of liver disease, just as adult biliary cirrhosis, cholelithiasis, drug-induced cholestasis, and intrahepatic cholestasis pregnancy. And this is very important, and we need to keep teaching our adult hepatology colleague about the PIFIC3, because I can tell you 50% of the cases now diagnosed and seen by our colleague from adult hepatology. So the PIFIC3 is really a disease of childhood and of adulthood. So this is the pyramid. So severe mutation will give you PIFIC3, unexplained cirrhosis, intrahepatic cholestasis of pregnancy, and unexplained gallstone. So also my advice to you, never do cholecystectomy for a child with gallstone. There is always something else behind this, even if there is no any cholestasis. So this is showing you our result post-liver transplantation. I just make it in general for our data. So for PIFIC1, comparing with international data, it is not good. And we are the same like them. There is 50% mortality due to allograft steatohepatitis. This is everywhere, and metabolic arrangement. There is a derangement, and there is 25% with allograft steatohepatitis, but still functioning graft, 25% with a modified internal biliary diversion doing well. And this is really our data. In the last 3 years, we start to think about something else in FIC1 deficiency. The problem, whenever we offer those families to do for them diversion, they don't agree. So in the last 2 patients of FIC1, we did for them internal biliary diversion, and we put them on protocol biopsy. And gladly, I can tell you that now we are following one of them almost 4 years now, or 3 years. There is no steatosis, there is no any problem, there is no diarrhea, and there is good growth over the time. We did the second case almost 6 months ago. So in my opinion, I think internal biliary diversion with the liver transplantation is really could change the pictures in FIC1 protein. We are planning to present this data in the coming SASPGHAN, inshallah. For PIFIC1, we have a very good prognosis, but we start to see a lot of cases, 6 to 8% with recurrence of the primary disease, and this is due to allogenic antibody against PSEP. What the meaning of this? That those patients you have, because they have severe type of mutation, truncated mutation, so there is complete absence of bile salt export pump. So whenever you put for him a new liver with a PSEP, this PSEP is totally new for his immune system. So there is unknown trigger cause for the immune system, which is will produce antibody against PSEP. This is will hit the active part, the apotype part in the PSEP, and this is will make the patient manifest again as PIFIC2. We were very lucky actually in managing those patients. So far we have 7. We treated all of them with modified protocol of plasmapheresis, rituximab, immunoglobulin, and even in the literatures, half of those patients require liver transplantation in our data, alhamdulillah, none of them retransplanted, all of them still alive with their graft, and 2 of them almost now they have follow-up for more than 7 years. So I will give you now some cases. So please, Dr. Hiba, whenever the time is coming, you can stop me. So 15 years old girl referred to me with a normal gamma-GT cholestasis, picture of decompensated liver, high bilirubin, positive family history of PFIC2. Her daughter her sister was post liver transplantation at the age of 2 years. At that time, she came with a very severe decompensated liver disease. When I took a history, it was showing that it is recurrent. She has been missed for a while. So when I saw her lab, her bilirubin was 335. Her INR was ranging between 1.7 to 2. And you can see her gamma-GT is normal with high liver enzyme. So if you looked, and her serum bile acid was very high, 355. So from the first look to this data, you will think that this patient already decompensated PFIC2, and she should to go for liver transplantation. But based on the history, based on our knowledge, we said, no, we need to see the mutation first, because this will guide us. So I did for her genetic mutation with Dr. Fauzan, and the mutation came that this type of mutation is usually benign one, and it causes benign recurrent intrahepatic cholestasis. So actually, I didn't do anything. I keep patients. I started her on high dose orso and high dose rifampicin, because rifampicin is the best whenever you have an attack of benign recurrent intrahepatic cholestasis type 2. And just with follow-up, her bilirubin went down to 11, her INR 2.9, and her liver enzyme normalized. So knowing the genetic mutation and having the knowledge of what this gene will do, prevent this patient from liver transplantation. Why she developed this severe attack at this age? Because she started her menarche, actually. So PSEP is one of the protein, will be down regulation whenever there is abnormal menstruation with girls. So that was really the main reason. And she came actually with a second attack. What I did this time, I just referred her to the obstetric. I talked to them. They give her medication. Her period start to be regular and no more attack. And she's on ursodeoxycholic acid. So this is being medicine post-liver transplantation. So allograft steatohepatitis and progressive familial intrahepatic cholestasis type 1 after living donor liver transplantation. This paper came from Japan. And they showed that those patients with a severe truncated mutation pre-transplant, they will have high risk of growth failure and allograft steatohepatitis. We have the same data. For the PFIC2, yes, truncated mutation is one of the major reasons, but actually we saw some recurrence in those with non-truncated mutation who is having very low level of PSEP protein. So it is not a must to have truncated mutation to have PFIC2 recurrence. And we have some truncated mutation, they do not have recurrence. So actually there is another immunological trigger factor unknown cause this recurrence, and until now it is unknown. This is another case, 35 years old a lady referred from our senior adult transplant hepatologist, Dr. Al-Gwaiz, and the history that she having intrahepatic cholestasis pregnancy and multiple abortion, normal liver enzyme when she came to me, normal bilirubin, normal serum bile acid, and she has a portion, she doesn't have any normal child. So based on the history, it's very clear that this lady was having some sort of MDR3 deficiency, and whenever she's pregnant, this MDR3 will be down-regulated, and then she will manifest the disease with high liver enzyme, high serum bile acid, and we know that the serum bile acid is very teratogenic and causing death of the fetus. So what we did, we just sent for her the mutation, and it came that she is really carrying the MDR3 heterozygous mutation, and that was the reason. So we did nothing. We just give her ursodeoxycholic acid, and she did well, and she kept following with me and Dr. Al-Gwaiz, and after that, she has 2 more children. So ICP is a clinical diagnosis. It's based on symptoms and on laboratory value. There are no specific radiological finding. And usually the raise in the serum bile acid are the most sensitive indicators of ICP. Serum alkaline phosphatase level are not reliable indicator of cholestasis in pregnancy because they are increased in normal pregnancies caused by increased production by the placenta, as we know, and the bone. Fetal outcome, there is a risk of premature delivery and stillbirth in 16%. Ursodeoxycholic acid is the treatment of choice if it is during the attack and early delivery, because the mom at high risk of death too. So the treatment to keep those on ursodeoxycholic all the time. This is one of our data about how Dr. Fawzan showed you that we have a lot of cases. I think we are over-diagnosing Wilson in our Gulf area. And I can tell you from the Wilson cases, I collected 50%, none of them Wilson, and all of them were MDR3. And this is when we present this abstract about how MDR3 mimic the Wilson disease in the copper content. And this is the reason that most of the people, when they do 24-hour urine collection and look for ceruloplasmin and these things, they will just label the patient as a Wilson, and actually more than 50% they are not Wilson. And this is really very important, because instead of giving the patient chelation therapy, this patient could be cured if you have early diagnosis by ursodeoxycholic acid. We published this data. Anybody can go back and see how we propose how you can differentiate between MDR3 and Wilson disease, and how you will have the common sense, or at least the high index of suspicion that this is not Wilson. So instead of giving the patient the wrong medication, you will start orso. And we know whenever you start orso early, it is treatable in some cases. Dr. Fawzan mentioned about this, and this is very scary actually. We have high disease burden of autosomal recessive cholestatic liver disease in our country. And you can imagine in a small cohort, it was 1 in 87. So this is telling you that a minimum disease burden of cholestatic liver disease in Saudi Arabia is 1 in 7,246. This is a very high estimate, even when compared to countries with a high burden of cholestatic liver disease in children like Japan. And this is very alarming, really, that something else needs to be done for the primary prevention through carrier screening. So what we are doing now, we have just medical management of cholestasis. We are proposing biliary diversion, and then at the end, the liver transplantation. We do not have a good experience in biliary diversion because most of our patients rejecting the biliary diversion. So now what is new actually? The new things now that people start to look more in the interior hepatic circulation. And as you see here, we have something called fixers. Just to make it simple, farnesoid X receptor is a bile acid ligand. So aspid, as I mentioned, will reabsorb 95% of bile acid. This will come to the anterior side of the TI. This will stimulate the farnesoid X receptors, and this will stimulate growth factors 19. And the growth factor 19 is the main player, in doing negative feedback on bile acid synthesis. So now most of the research now going how to bring a medication to treat PFIC 1 or PFIC 2 or even PFIC 3, it's how to play with aspid. So you need either to bring fixer agonist, or you wanted to give aspid inhibitors. Because if you give aspid inhibitors, it is very clear that you will decrease the amount of serum bile acid, which is toxic, which will run through the interior hepatic circulation. I think all of you are aware about the break news in the last 3 years, where there was one of the medication of the fixer agonist came to the market. It was already approved by FDA to be used for primary sclerosing cholangitis. But actually, after 1 year, it showed the result was not very good, and there was some very bad side effect. So still, there is a lot of research working on fixer, but the other group who are working on aspid inhibitors, they start to show some good data. So they did phase 1, they did phase 2, and then we joined them at phase 3. So in phase 3, when we saw all the data of phase 1 and phase 2, which was promising, then actually we joined them. Initially, the plan was to just use it for progressive familial intrahepatic cholestasis type 1 and type 2. And there was a very strict inclusion criteria that the serum bile acid is more than 100, bilirubin is below 100, with a high liver enzyme is not more than 10 times, normal coagulation, so the INR less than 1.5. So this was the inclusion criteria. We have many meetings, and then we start to be part of the study. And the primary objective was to demonstrate the efficacy of repeated daily dosage of the investigator medication in children with progressive familial intrahepatic cholestasis, as determined by change from baseline to week 24. So we were looking to pruritus, fasting serum bile acid level, and compared to placebo. And it was double blind. It was very clear that the idea that whenever you are playing with the bile acid, you will also stimulate the intrinsic growth factor 19, which is indirectly will inhibit the bile acid synthesis, and this is how it will help for itching. The pruritus was the main things to measure, and at the same time, whenever the serum bile acid will go low, which is toxic one, this will improve many things, will improve the absorption of fat-soluble vitamins, will decrease the hepatocyte damage, and we will see if this is helping or not. So actually we finished, just to make it easy, this is really everything going through fixers, and for anyone interested, I can send this link. There is now a fixer research going on in Phoenix, and people now thinking in fixer in many things. Bile acid is one of things. So whenever there is a farnesoid X receptor action, they found they play with lipid metabolism, carbohydrate metabolism, immunity, bile acid metabolism, and now people talking about the relation between fixers and bile acid and NASH. So actually all the science now is between fixer and aspect, and if there is any treatment will came out to PEFIC, it will be from those two pathways. So this is just to show you how the growth factor 19 will play. So actually growth factor 19 will make a negative feedback on the bile acid synthesis pathway. So it will decrease bile acid synthesis, it will decrease lipogenesis, decrease gluconeogenesis, increase regeneration. So I mentioned about the inclusion criteria, and I can tell you after we finish now, we are almost at the end now, and we finished the phase 3. Now we start the open label now, and the drug already approved by FDA. I think the paper will come soon in Lancet of Nature, and it's now breaking news really in the progressive familial intrahepatic cholestasis medical treatment. But I wanted to show you to mention one important thing: this medication working mainly on those with a milder type of mutation, not PRIC. Again, they are BIFIC2, but not all the BIFIC2, they have severe type. So actually, we look to the type of mutation. Whenever there is truncated mutation, patient will not be included in the study. So all of those patients who have been in the study, we check their genetic mutation, and we excluded all the patients who's having truncated mutation. So now we are in the open label phase, and in my opinion, I think the drugs is very promising if you choose the right patient. Now we are in the open label, so we start to use it for BIFIC1, BIFIC2, and BIFIC3, again with the same criteria. And you can see that the inclusion criteria were very safe, so none of those patients could be high risk for malignancy, could be high risk for, or he would need transplantation. We have cases of severe coagulopathy, but it was cholestatic coagulopathy, which is corrected by INR, because we should differentiate. You could have BIFIC2 with INR of 8. This is not a liver failure, especially when you see your bilirubin is normal. Give this patient a high dose of vitamin K, and the INR will be corrected to 1. So, but when you have high bilirubin, high serum bile acid, and the INR is high, this is telling you that this is coagulopathy due to poor liver function, and there is difference between the two. So this is just showing you that this is the press release in Boston about the medication that they announced agreement to the medication in Saudi Arabia with Gen Pharma. So I think the medication will be available very soon for everyone in the Gulf countries through Gen Pharma. And so the conclusion, so this is a good treatment for milder type to moderate type of mutation, and mainly it will improve the itching. And this is very important. We have many cases of BIFIC2. The main reason driven them to liver transplantation is intractable itching, not not controlled by medical treatment. And we know that the tractable itching is incompatible with normal life. So actually, those are the main patients who really get benefit of the medication, and this will also prevent them from liver transplantation. So the question is, this will prevent HCC? This will need time to study, to wait. Is it a treatment for PFIC1, especially after transplantation? Is it a treatment of allograft steatohepatitis post-liver transplantation? This is another thing. I think time will tell, and people now really talking about the same medication, the same pathway. Is it helpful in NASH? Actually, nobody knows all of this. This is totally new things. The medication just licensed, and I think time will tell. Thank you.
Thank you so much, Dr. Mohammed Shagrani, for this excellent and amazing presentation. Now we'll move to the questions for it. Okay, let's start with this simple questions, asking about how the orthodeol working and becoming an essential medication in cholestasis. Yes,
let us say that it is not essential medication in cholestasis. Okay, I think orthodeol is a heritage medication in cholestasis more than to be essential part of medication. We should to know that orthodeoxycholic acid is one of our bile acid. It is present in a percentage less than 1%. It is a benign one. So actually, the idea of orthodeoxycholic acid, it is cytoprotective mechanism. Okay, and whenever you increase the level of oxygenic bile acid, you will decrease the synthesis of toxic bile acid. So we shouldn't believe it is a treatment in some disease. When you talk about PFIC3, yes, orthodeol is a treatment because the way, the pathophysiology of PFIC3 is exactly will be inhibited by orthodeoxycholic acid when it is given in the right time. And I can tell you over the years, I have not less than now, I collect the data, we have around 20 patients of PFIC3 in our clinic who we were very lucky in diagnosing them very early, and they are doing very good on orthodeol. So let us say that orthodeol is not a treatment for everything, okay? The other question is, orthodeol is toxic to the hepatocyte. Again, the data which is mentioned about toxic, they said we give up to 30 milligram per kg per dose, but they compare it in a patient who were very sick. So I think that data was biased. So still, my experience, I'm very liberal in using orthodeoxycholic acid in cholestatic patients. If someone will ask, even in Alagille syndrome, who's having biliary hypoplasia, even in biliary atresia, who's having obstruction, because the pathway is not to increase, let us say, the bile acid flow through the biliary system. It is mainly the cytoprotective mechanism for the hepatocyte.
Okay, another interesting question is asking about have you used the drug in post-liver transplant patient with PHEP who present with etching?
Sorry, again, can you repeat the question? Sorry.
The question says, have you used the drug used in your clinical trial in post-liver transplant patient with PHEP who present with etching?
And no, we never use it. Actually, until now, they use only for PFIC1 and 2. Now, in the open label phase, we are trying to include PFIC3, but so far, we didn't use it for any PFIC3 patient. We use it only for PFIC2 and PFIC1.
Okay, another question about the same drug. Do you think that it will, one time will have a treatment for PFIC? Medical treatment rather than transplant?
Cholestatic is very, very upsetting for us as physicians, because until today, with all of this science written, with all of this knowledge, until now, we don't have a single treatment for one of those cholestatic liver disease if you will exclude the bile acid synthesis defect, and even in bile acid synthesis defect, most of the cases need to be discovered very early with a milder type of mutation, because all the cases I saw with bile acid synthesis defect, none of them came to us early, none of them respond to cholic acid, and I confirm that we have different genotype of the bile acid synthesis defect. So yes, I think in the future, especially when again, in the milder type of BIFIC 2, as an example, as I mentioned, we have some BIFIC 2, and I'm sure many of you, they saw those patients. Their bilirubin is not very high, their INR is good, but their serum bile acid is very high, and they have severe itching and use all the medication. You cannot do diversion. So actually you send them for liver transplantation because of intractable itching. So at least if we will start by preventing those patients from liver transplantation, this medication will be one of the milestones to have the experience of finding medication in the future to treat PIFIC. Many diseases, no one was thinking that there is will be treatment for it, but then with time, I mean, there is medical management. So I think, yes, we should to be very optimistic. And there is a huge group working on bile acid metabolism and bile acid pathways. And I think more things will come in the future.
Yeah, just to comment on this question, the set of questions was about the using of this drug in PSAP who present with itching, who had antibody against PSAP post-liver transplantation, just to be more specific.
You mean to use this medication for?
Yes, her question is using this medication in PIFIC 2 post-transplantation when they have antibody against PSAP.
I don't think so this medication will work. It's never been tried. I'm just mentioning ideas. It's never been tried. Personally, I don't think so it will work. It could improve the symptoms, but now you have the PSAP is totally affected because you need this antibody to be out and you wanna to suppress the B cells. And this is the things that we did a modified protocol, because when I look to the literatures, everywhere there is no specific treatment. Some people talking about modification of immunosuppression, and some people went to the extreme talking about bone marrow transplantation. So actually, I don't think so this medication would work. Those patients, they have totally different pathways. There is a B cells activated, there is allogenic in the system, and we managed to isolate those antibody. We did for them titers with a group in Düsseldorf, and we showed that this titers thousands, and it is against PSAP. So without attacking the B cells, without washing the blood out and taking the anti-PSAP out, you will never control the recurrence. This medication will not do any one of this. This medication could work on the symptoms part and decreases the amount of serum bile acid. But as long as you have an antibody attacking the PSAP protein at the most important part of the protein, then I don't think so this medication will solve the problem.
Another good question about the recurrence of PIFIC type 2 post-transplant. Would you prefer cadaveric liver transplant to living related for PIFIC type 2, or this is not an issue?
Yeah, this is very important question. Actually, if you look to the literatures, the first recurrence published was in 2009. It was a Saudi child transplanted in military hospital. The donor was one of the parents, which is mean we give heterozygous to homozygous. And then the patient after transplantation showed the pictures of cholestasis. At that time, nobody knew that this is recurrence of the disease or not. Patient went to Germany, transplanted again from cadaveric, a child from Austria, and then he ending with the same symptoms. And then the patient went to New York, and in New York, they were trying to do medical treatment, and then he died. So he died after 2 transplants, one of them from heterozygous, one of them from homozygous. And then after the child died, they discovered that this is recurrence. So let me tell you our experience. We have so far 7 recurrence, 4 of them from cadaveric, 3 of them from heterozygous donor. So I can assure you that giving heterozygous liver to homozygous, it is not increasing the risk of recurrence. because as you know, our program is 95, maybe up to 97%, it is living related. So most of the time we are doing heterozygous to homozygous. So actually, if the theory that heterozygous is one of the reasons for recurrence, then we shouldn't have single patient. Actually, more patient from cadaveric than patient from heterozygous donor. So I don't think so at all that having the donor as a carrier increase the risk of recurrence in BIFIC2.
Okay, another question about is there any, about the medication, the new medication, is there any harm of using the new medication in treating the itchiness in moderate to severe cases of BIFIC?
Depends actually, because if you all tell me moderate to severe type of BIFIC, then it's mean this patient already in a list for liver transplantation. So if you will give this medication now as a bridging until you transplant the patient, yeah, nobody will blame you. But actually depend on the price and how the medication will be available, because I think you need to limit the use of the medication to the patient you are sure 100% they will get benefit. There is no point to give the medication for a child with BIFIC2, his bilirubin hundreds and his INR is 3, and he's already in liver failure to improve the itching. I don't think so. This will be justifiable, especially if we will expect that the price of the medication, I think it will be very expensive at the beginning.
A question about the MDR deficiency mimicking Wilson disease. Is it harmful if we treat it with copper lowering agent? Especially that gene study will need some time.
Depend. If you will, I can tell you how we discover actually these things, because actually on the same year we discovered it was the first 2 cases published by a group from Johns Hopkins about 2 adolescents came with Wilson disease. And to be honest with you, we discovered this ahead of them, but they publish it ahead of us. So yes, there is a harm. And I will tell you how we discovered this actually. I was collecting all the patients with cryptogenic cirrhosis, and then Dr. Faisal Abul-Khail and Dr. Hussein Al-Sisi, who's our colleague from adult hepatology, they told me that they have explanted liver of Wilson patient young with HCC. And those patients were between 15 and 25 years old. And then I told them, there is something else. I don't think so. Those patients were Wilson disease for sure. They were having underlying cholestasis, because as you know, whenever you have long live cholestasis, this will increase the risk of HCC. So what I did, we just took blood from those patients. And then at the same time, I took some blood from my patient with Wilson, because in most of the cases I was thinking that they are overdiagnosed, because you know, when you label patient as Wilson, then you will not do anything else. You will give him chelation therapy and he could stay 10, 15 years in this. And this is the time we discovered that all those patients labeled Wilson with explanted liver HCC, all of them were MDR3 deficiency. So yes, it is harmful for them. You will give unnecessarily medication. This medication causes another side effect, either renal issue, hematuria, whatever complication. And at the same time, you keep the patient away from the right medication at the golden time.
Yeah. I think we'll take the last 2 questions. Do you recommend to do genetic study for any patient with decompensated liver disease, likely genetic, before proceed to liver transplantation, even if there is an index case? And
this, I'm not sure if Fauzan is here or not. Again, guys, not all of you in a place like King Faisal, you have the genetics. So we cannot now do, it is like a show now, we have all the facilities, so I'll tell you it's easy to diagnose. So no, I do believe that clinical sense should be there. This is number 1. Not everyone have the facility for genetics. Okay, so I didn't blame you. But again, I think having the knowledge, how you look to MDR3, how you look to Wilson, how you look to BIFIC2, this is also will increase your clinical sense. It is, I can tell you recently, I can say 90% of the cases, the genetic diagnosis is going with our clinical impression, especially with the experience, with the volume, with looking to the patient. So I don't want you now to think that without doing anything, just do genetic testing and you reach a diagnosis. This is number one. Number two, it is not a must to do genetic testing for decompensated liver before sending the patient for liver transplantation. You could actually affect the patient. Patient could deteriorate more while you are waiting for genetic testing. And we are doing this even here. So actually, you want to just to have the clinical sense how to rule out systemic manifestation. Just taking one example, you have a patient, 2 months old, he's in liver failure. Okay, your genetics is not available. So do all the workup and your clinical exam and the history, which is at least can rule out systemic disease like mitochondrial cytopathy as much as you can by doing all the clinical things. And then if you did everything, you ruled out this, send the patient for transplantation and counsel the family that yes, I'm not sure 100% that this is a disease only of the liver, but I did everything to rule out mitochondrial disease or systemic disease. And if you look to the literature, many centers, they have everything, and still they transplanted mitochondrial cytopathy because the time they wanted to diagnose, it was in the initial 3 months, whereas the MRI is normal, hypotonia cannot be assessed, and the rest of the lab is good, and some of them have novel gene, so the genetic mutation came to be negative, and then after transplantation, they discovered that he is mitochondrial disease. So the question, I don't think so, it is a must when you do your homework rightly.
Okay, last questions, Dr. Mohammed. Sorry for it. I need to cover most of the questions before wrap up. You mentioned in the last slide that heterozygous mutation can cause like a phenotype of perfect. Can you comment on that?
About MDR3.
Yeah,
I was talking about MDR3. MDR3 is totally different story. And if any one of you following the MDR3 new issues, so there is no clear explanation, okay, why, but MDR3 is totally different because even they are heterozygous, but during life, there's many things will cause for them more down-regulation of this protein, sometimes drug-induced liver injury. And some of them, as we mentioned, pregnancy. And some of them, they could be exposed to other medication. They could be ill. And this is the reason there is down-regulation of MDR3. And if you look to the King's College group, led by Dr. Richard Thompson, they stop now any heterozygous MDR3 to be a donor because their data now showed that by following those patients, both of them, the donor and the recipients, developed cholangiopathy after 10 years. And the advice now, if it is a must in you to take a heterozygous MDR3 because you don't have other donor of the family and you will give it to homozygous, both of them need to be on orthodeoxycholic acid. And after we saw the data of King's College, all of our patients, MDR3, post-liver transplantation from heterozygous living donor, they are on orthodeoxycholic acid for life. And strongly, I do believe in this. And we have some cases, my personal opinion, it is a recurrence, but we could not confirm any anti-MDR3 up to today. We sent all the blood, it is under study in Düsseldorf, but we have no result. And the same impression from Richard Thompson group.
Okay, I think at the end, before going for one announcement, I would like to thank you again, Dr. Mohammed Shagrani. I think no one can explain this topic better than you. Thank you for your amazing contribution and presentation and sharing your experience. Thank you so much.
شكرا جزيلا لكم جميعا واعتذر عن الإطالة. I was so happy to be with you. شكرا لكم.
Thank you so much, everyone. Thank you, Dr. Ahiba. Thank you, Dr. Mohammed. Also, we'd like to thank the Dr. Fawzan for this nice presentation. Really, we enjoy it. And inshallah, upcoming events will be more nice and like this one. By the end, I would like to announce this coming event, which will be the 7th International SASPGHAN Conference and Exhibition 2022. Which will be held in 10 to 12 February. It will be actually physical attendance at Intercontinental Jeddah. And you can follow us on these our accounts. And looking forward to see you there. Thank you so much, and stay tuned. Thank you.